our speakers, chairpersons, moderators, and all the attendees from all over our MENA area. So we are today with the next module, GU malignancies. And on behalf of CRG, Dr. Fadi Farahat and myself, the AMAC, Arab Medical Association Against Cancer, we are welcoming all of you. And please note that our activity is endorsed by the ASCO, UICC, and AMAC, and it's awarded by 2 CMEs. So you are welcome. I will introduce the chairman of this session, Dr. Deborah Mukherjee. Dr. Deborah is she is associate professor at the American University of Beirut and medical oncologist at Clemenceau Medical Center, United Arab Emirates. So, Dr. Deborah, the floor is yours to present our moderators and to start the session. Thank you all.
Thank you. Thank you very much, Dr. Khatib, and welcome to all of our attendees. It's a great pleasure to be with you virtually today. So it's my pleasure to introduce your moderators for this evening's session. Dr. Joseph Khattan, Professor Khattan, needs really no introduction, Professor of Medical Oncology at the Faculty of Medicine, University of Saint Joseph, and the head of the Department of Hematology Oncology, Hôtel de France in Beirut, in Lebanon, and Dr. Ziad Marwawi, radiation oncologist and head of the Urogynecology Department at the Al-Biruni University Hospital in Syria. So it's a great pleasure to welcome everyone today, and we'd like to start with our moderators introducing our first speaker, who's prepared for you some wonderful cases. So we'd like this to be as interactive as possible. Thank you very much.
Thank you. We can start. Thank you, Dr. Deborah. At the beginning, I want to thank Dr. Farhad, Dr. Sami Khatib to participate in this important meeting. So in this meeting, we'll start with Dr. Ala Abu Farah. Dr. Ala Abu Farah is a medical oncologist at King Hussein Cancer Center in Amman, who will talk about quiz on prostate cancer castration resistant. Please, Dr. Ala.
Okay, thank you. Can I share my slides or?
Yes, you can, please.
This okay. Next, please, Doctor. At first, there will be three questions to squeeze our brain, to warm up our brain. The question is, who is the best football player into 2021? Is it Ronaldo, Messi, Mohamed Salah, Abu Gabi, or you don't know the question, the answer?
Okay.
Okay, actually, I don't have any idea about this question. Who is the best one in the 2200? I'm not a big fan of football. The next question. The next one. How you are confident right now in your ability to formulate individualized treatment plan for your patients with metastatic CRPC who progress after treatment with docetaxel and androgen receptor inhibitor, ENZA and ABI? Are you extremely confident, very confident, somewhat confident, not so confident, or not all confident? Please answer. Somewhat confident, the majority of audience, 56%. The next is not so confident. I think after progression of docetaxel and androgen targeted therapy, you have to look for the somatic or germline mutations to personalize the treatment. So I am with somewhat confident because patient progressed on these two lines, they do bad in overall survival. Case one is around 90-year-old man who diagnosed with prostate cancer 7 years ago, and his status post-radical robotic surgery, prostatectomy. At the time of diagnosis, he had Gleason 7, 3+4 disease with perineural invasion, but negative margin on resection, no disease outside the prostate on image, and initial PSA is 5.2. Following the surgery, the PSA became undetectable, but began to rise 2 years after surgery. The patient then received definite radiotherapy to the prostate bed with the initial downtrend in PSA. After 2 years after receiving radiation, his PSA once again began to rise. Restaging scan were negative for metastatic disease. He was started in injection of loperamide injection and bicalutamide, and his PSA dropped. However, after 8 months of therapy, the PSA began to rise from nadir 0.9 to 1.3 in 12 months. In the next 12 months, the PSA increased to 2.1 nanogram. Restaging scan again for metastatic disease were negative, and the serum testosterone is 3. The patient has no any urinary symptoms. So the question is, what is the next most appropriate step in management for this patient? Discontinue loperamide, bicalutamide, and start docetaxel, prednisolone, or you have to discontinue loperamide, bicalutamide, and start cipuricil, discontinue loperamide, bicalutamide, and start radium, discontinue the ADT, bicalutamide, and start abiraterone, or discontinue bicalutamide and continue loperamide. The answers, please. So the majority answer with discontinue loperamide, bicalutamide, and start abiraterone. 46%. 31 is the last option, discontinue bicalutamide and continue ADT alone. I think there's no there is no data. This is a biochemical failure, and there was no randomized trial comparing the role of ADT versus to keep the patient on observation in those patients. But the adding ADT is an effective form of therapy in this patient. Now, the addition of further treatments like chemotherapy, like androgen targeted therapy, this was addressed in multiple trials, several trials. But I think abiraterone is still not one of them standard of care. There are 3 other agents, enzalutamide, apalutamide, and darolutamide. If I lean to answer this question, the last answer is to continue loperamide alone, if you agree with me.
True, yes.
Certainly, I agree. So if I want to comment on this in this patient, we forget this category of patient who are hormone resistant, non-metastatic, and they have no features of aggressivity with a doubling time less than 10 months. So these patients are usually, like always, are under wait and see. So we are following these patients. So even the option to keep the ADT plus bicalutamide is not wrong, but what Dr. Abu Farah proposed is what we call for the old generation, the flutamide withdrawal syndrome. If you remember Howard Chair from Memorial, he described this phenomenon But at that time, we don't have options. So for these patients who have a PSA relapse, increase, a biochemical relapse, and we don't separate the doubling time less or more than 10 months. We don't have options. So all these patients were on wait and see. And at that time, Cher proposed to stop the flutamide, the anti-androgen, peripheral anti-androgen, like bicalutamide. And he obtained in 30% of patients a PSA reduction, which lasts at least 3 months. So for the old generation who can remember this option, we can now suggest to this patient, stop bicalutamide, like Abu Farah proposed, and continue ADT.
I agree with you, Dr. Qattan. This patient, I don't think he has a relapse after 2 years. Just biological relapse, imaging bone scan or CT scan, there isn't any metastasis. So this is a biological relapse. We can continue with the ADH with bicalutamide or without bicalutamide.
Okay.
Okay. The second question. Thank you. Second question is the 70-year-old man with metastatic CRPC has progressed through multiple lines of hormonal and chemotherapy. He has a good performance status and is being assessed for enrollment in clinical trials assessing the efficacy of PARP inhibitor olaparb. The question is, please next. Which of the following molecular traits confers the greatest chance for the patient to respond to this drug? ATM mutation, BRCA2, CHIK2, Fanconi anemia gene mutation, or MSI is high. The majority, 85% BRCA2, 5% ATM, 10% MSI. I agree with the BRCA2. BRCA2 mutation had 100% response rate to olaparb, and this was addressed, I think, in PROfound trial, comparing the olaparb versus abi or enza, and it was better, the olaparb, in patients with BRCA and other mutations. The other mutation has less response rates, the ATM and the CHIK2. The MSI, this is they may predict response to immune therapy and not to PARP inhibitors. Okay, question number 3, 61-year-old man with the history of Crohn's disease. He has metastatic CRPC, present for follow-up. He has disease progression through multiple lines of therapy, including leuprolide, abiraterone, enzalutamide, and he recently also finished 6 cycles of docetaxel, prednisolone. The restaging bone scan demonstrates progressive disease of his skeletal M1, and CT scan demonstrate a new liver lesions. The patient's PSA has risen from 11 to 50 over the last 3 months, increasing pain from his skeletal metastasis, but he's still able to care for himself and works part-time. The question is, which of the following is the next appropriate step in this management of this patient? Cabazitaxel, prednisolone, hospice referral, metoxantrone and prednisolone, pembrolizumab, or radium-223. Please answer. %, of audience answer cabazitaxel, and 14 for radium, 9 for pembrolizumab, 5 for metoxantrone. I will go for cabazitaxel. I think this is the correct answer. and the role of cabazitaxel was addressed in TROPIC trial comparing the cabazitaxel versus metoxantrone, and it was better overall survival. I think radium in this patient will not be the correct answer because the patient has liver metastasis. Keytruda or pembrolizumab also the data is not well mature, and also the patient has autoimmune disease, so it is not the correct answer. I think the cabazitaxel is the correct answer in this case.
A very interesting case, Dr. Ala. Maybe among the options, we can add the search of BRCA1, BRCA2 mutation. So like the case 2, so it's an option, and even there is a school, and maybe I think they are testing BRCA1, BRCA2, and giving olaparib in case of positivity, even before the docetaxel, before chemotherapy. So it's an option if we have the opportunity to test this mutation.
Yes, Joseph, I concur with you. The other question that I'm putting, maybe for all the patients that are metastatic, we should look at the BRCA probably.
I have another comment about the role of liver biopsy, because sometimes we pick up neuroendocrine disease, particularly in patients who've had a lot of treatment. So that's also something which is in the guidelines to consider a liver biopsy.
Okay.
Absolutely. Yes. I think it's not a regular place to have a liver metastasis in the natural history of prostate cancer. We have to think about this option, Deborah. Very good remark.
Usually in the neuroendocrine, the PSA will not rise. The initial biopsy will contain sometimes neuroendocrine features or components, but yes, sometimes in 15%, the adenocarcinoma due to treatment with ADT will transform to neuroendocrine. Yes, liver biopsy, one of the option akid.
Next case.
The next case is a 73-year-old man. He's seen in clinic, diagnosed with localized high-risk prostate cancer 5 years ago, and has a history of MDS. At that time, the diagnosis, patient underwent radical robotic surgery followed by adjuvant radiation. He subsequently developed biochemical relapse within 1 year with PSA doubling time of 4 months. He was started on leprolide, but eventually developed metastatic disease. His PSA is 15, and his total testosterone level now is 8 nanogram. White BCs is 6,000. Hemoglobin is 8.7 gram. He's anemic, and the platelets 140,000. The CT scan showed 2 sites of metastatic disease in the left ileum. So the question is, what is the next appropriate step in management of this patient? Cabazitaxel, prednisolone, continue leprolide and bicalutamide, continue leprolide and add enzalutamide, and docetaxel, prednisolone, or radium.
Fadi, we saw the answer.
Sorry.
Well, that's the most pertinent.
It's not the answer, it's the comment and the rationale which is important.
Yes.
Yes, the majority, 87% answer to continue ADT and add enzalutamide, and minority 9% with to continue only ADT and add bicalutamide. 4% they vote for chemotherapy. I think he had the low volume disease with 2 bone lesions, so chemotherapy is not indicated in this case. He has an MDS, so cannot give radium because he is anemic, but this is out of options. because he has a high risk disease, and even if he has low volume, we have to add another agents to the ADT. So we cannot continue only ADT alone. So I vote for to add enzalutamide, and this was addressed in STRIVE trial. The adding of enzalutamide was in those patients reduce the risk of death and reduce the progression in this category of patients. So the answer was correct in the majority of audience.
Maybe the fact that he has MDS was put just to exclude the use of chemotherapy also.
Yeah, and the other point also for using the radium-223, there are two contraindications here: the bone marrow reserve,
Yes.
which would be a problem with the radium-223, and also the liver metastasis, so which is contraindicated. You have to have just only a bone met
Just bone.
with bone marrow reserve. However,
He has bone.
yeah, if he progresses in the future, maybe the other novel agents can be used. Like we'll see, there is a cross resistance with the abiraterone, as we gonna discuss later on. But maybe even a dose reduced or weekly docetaxel in a such patient might be used, and watching maybe just the bone marrow, especially the anemia.
Doctor, we have a bad experience with weekly docetaxel. In the TAX trial, I don't remember the number, it was shown that it was equal to the third arm, only 3 weekly docetaxel. So my question, your comment is needed. Do you try still to give docetaxel on weekly basis? In such case?
Honestly, no. But in this patient, you have two options: either to reduce the dose of the docetaxel every 3 weeks to a 60 or to a 50, and then escalate or de-escalate according to the response and tolerance. But I asked this question even 2 weeks ago to Dr. Fizazi, and they are away from this weekly docetaxel. However, in this patient, because we don't know what's his bone marrow response will be to the chemo. And
sure. On the other hand, we have other options.
But
Dr. Can I ask you a question? If we go back to the history of the patient, where is the exact time that you can ask for PET PSMA? There is a place somewhere when PSA increase. It's the ideal situation where we ask for PET PSMA, I think, no?
Probably.
When he get a biochemical relapse. So now if we have the access, we can perform PET PSMA to see if there is any metastatic infraclinical metastasis.
The other point is metastasis-directed therapy. We now have some phase 2 data from the STOMP trial about the role, particularly in someone who's not very fit for chemotherapy, and you're concerned about their other comorbidities. So metastasis-directed therapy is something that we've been using a lot.
Good. Do you want to move to the next if there is no comments?
Okay. Next, fifth question is, next, please.
Case number 5, it's shown.
Is Edward, he is a 50-year-old teacher, recently diagnosed with metastatic prostate cancer. He has free medical history, echo performance 0. He's asymptomatic. On bone scan, he has a T11 bone mets, CT scan, locally advanced prostate mass, a few enlarged lymph nodes within the pelvis, no signs of visceral metastasis. The PSMA showed also 2 spots of bone lesion, 1 positive lymph node outside the pelvic area. The PSA is 19. Prostatic biopsy showed Gleason 8 adenocarcinoma, ISUP grade 4. The question is, which treatment option would you choose for this patient? ADT alone, ADT plus radiotherapy to prostate, ADT plus systemic agent, ADT plus radiotherapy to the prostate and systemic agent. The answers, 37% of answers were to the last option, which is ADT plus radiotherapy plus systemic agent. 26 voted for ADT alone, and 21% for adding radiotherapy to ADT. 16% ADT plus systemic agents without any radiotherapy. This patient has a low volume disease, low metastatic disease, and he has a high risk prostate cancer, glycemic score 8, PSA 19. So I think adding radiotherapy to ADT plus systemic therapy was addressed in 2 trials, HORAD and Stampede, and there was a survival benefit. So adding radiotherapy, this is a must. Plus the systemic therapy. The systemic therapy here is not chemotherapy, because we know from the charted trial, the low volume disease, they did bad with chemotherapy. But on the other hand, adding androgen-directed therapy like ABI or INZA or apalutamide give a good benefit in all subgroups, low volume and high volume. So my vote was to the option, the last option, which is ADT, radiotherapy, and systemic therapy.
I agree with you, Dr. Ala. Radiotherapy plus ADT, less than 3 metastases of prostate cancer, we can go ahead by radiotherapy with ADT. But what about the radiation to the metastasis in the same time? What do you think about that?
Exactly. I think also that now the SBRT to the metastatic site plus to the radiotherapy to the prostate became the I think the standard of care. SBRT to the metastatic site plus to the local disease, to the local disease.
Yes.
This will actually be the next arm of Stampede. So Stampede is going to add an arm of metastasis directed.
I think we finished the questions.
Okay, the floor is yours.
Thank you, Dr. Ala. What's very interesting. So to start with questions and discussion and a very interactive session. And it's now my pleasure to introduce our next speaker, Dr. Muhammad Musa. Dr. Muhammad Musa, he will be presenting a pre-recorded presentation. Dr. Muhammad Musa is a professor of urology, dean of the Faculty of Medicine at the Lebanese University, and the chair of urology division at Zahra University Hospital, Lebanon. The title of this presentation, Prostate Cancer Diagnostics. So we are going back to the early stage. Prostate Cancer Diagnostics, Challenges and Need for Disruptive and Effective Diagnostic Tools. The floor is yours, Dr. Muhammad Musa.
So, good evening, ladies and gentlemen. So, good evening, ladies and gentlemen. I would like to thank Professor Fadi Farhat for his invitation to this ABC Oncology Educational Course 2022 and the latest update about prostate cancer. My talk will be today, challenges and need for disruptive, effective diagnostic tools. My outlines: introduction, PSA isoform, and other biomarkers, prostate biopsy technique, MRI ultrasound fusion for prostate biopsy. I have no disclosures. Why prostate cancer is so important? Because it's having high mortality rate and high incidence rate. And if you see the distribution in US and worldwide, what about prostate cancer detection? It is controversial. Why? Because we have to balance between benefit and harm. Benefit, early diagnostic, save lives, and harm if you will operate, if you treat prostate cancer, which are insignificant. There is a rapid changing paradigm. We are having PSA and prostate cancer in 2021, the good, the bad, and the ugly. The good, if you can decrease the mortality rate till 50%, if you make an early detection of the cancer. The bad, if you will overtreat the patient and overdiagnose. And the ugly is the cost of the screening. Prostate cancer screening saves lives, but need to minimize overdetection and overtreatment. As you know, prostate cancer is common among men dying of other causes and is increasing with age. A Swedish randomized study of screening patients in European Neurology 2015, in 1994, 20,000 Swedish men were randomized to PSA testing every 2 years and a control group. The PSA threshold to recommend biopsy varied between 2.5 and 3. Follow-up for 18 years, and what they found out through this screening that the test from prostate cancer is 1.5% in controls versus 1% in the screening group. And this means the screened men, they have 42% lower risk of death from prostate cancer. The European screening study from Schroeder 2012, 182,000 patients were screened every 4 years and follow-up of 11 years. And it has shown that there is a relative decreased risk of death from prostate cancer by 21%. And the number of men needed to treat to prevent one prostate cancer is 37.
It seems we have a
AUA guidelines for early detection of prostate cancer. If first point, patients less than 40 years, no screening. Patients aged between 40 and 54 years, no routine screening if average risk or low risk. Age 55 to 69, shared decision-making based on values and preferences. Routine interval of 2 years or more may be preferable over annual, individualized by a baseline PSA level. For patients over 70 years and a life expectancy of less than 10 years, no routine screening. This is the NCCN Guidelines 2021. And what about if the PSA suddenly increase? What about the PSA velocity? Higher the PSA velocity, it has been found to is likely to be more infection rather than prostate cancer. And if you find this increase of PSA, the velocity is high, don't do biopsy right away. Try to find out the cause and to do more imaging and consider more parameters to decide. What about when to stop to check PSA? We consider stopping PSA, as I've told you, after the age of 70 and the low life expectancy for males, and at the age of 60 if the PSA value of 1.09 nanogram. It has a low decrease cancer. We will not find a prostate cancer if the PSA less. It's very rare to find a cancer if the PSA is less than 1 at the age of 60. What about screening biomarkers? Biomarkers are important for borderline PSA between 4 and 10, and for patients who are not willing to have biopsy because of the side effects of the prostate biopsy. These are the biomarkers available. They are in serum, in urine, and in tissue. What we have in Lebanon is the 4K score. The 4K score at 4 kallikreins, total PSA, percentage of free PSA, intact PSA, human kallikrein 2, combined with age, digital rectal exam, and previous biopsy, calibrated to predict a risk of Gleason more than 7 on biopsy. And this is a patient 4K score final report. This patient is 76 years old, a digital rectal exam negative, prior biopsy yes, and was negative, a total PSA of 6.23 and the ratio 21, and his 4K score test result is 5%. This means at 4K score test result of 5%, about 1 in 20 men biopsy would have high-grade prostate cancer, 1 to 20 possibility of having high-grade prostate cancer. And you have to decide for yourself to biopsy or not. This is the validation of the 4K score. This means to avoid 30 to 58% of biopsies with delayed diagnosis of Gleason more than 7 in 4% of all men in cohort, and 6 in 21% of all men with Gleason more than 7 on biopsy. Prostate Health Index, this is a mathematical model developed by Beckman, called for a combined score. This is the formula. And if higher PHI score, more likely to be significant cancer. And the urinary TMPRSS2, and this is also a urinary biomarker. You have, using this biomarker, 33% fewer biopsies and 3% of men with delayed diagnosis of grading group 2. Select MDX, also a urinary mRNA, reports risk of any cancer, reports risk of Gleason more than 7, 99% for Gleason score more than 8, 95 to 98% for Gleason score more than 7. The X exosome, also urine-based 3-gene exosome expression assay, and this test decreased the biopsy rate by 27% and decreased diagnosis of more than Gleason score cancer by 8%. Confirm the X only for repeat biopsy patients, and this is the epigenetic assay, Tumor Halo. This is the circle where the tumor is inside, and you make biopsies around, and you don't find the tumor. This is through a DNA methylation, and with this test, you will have all cases with Gleason more than 7 had methylation changes, and you can identify those patients who are adequate for biopsy. What about genetic counseling in prostate cancer? Etiology of prostate cancer, sporadic 70% due to chance or environment, general population cancer risk, hereditary 5 to 12%, non-single gene mutation, familial 20%, combination of multiple genes and or environment. And among common cancers, prostate is the most heritable. 42% of prostate cancer due to inherited genes rather than environmental factors. However, only a small portion of heritable prostate cancer have identifiable germline mutations. We know that it is hereditary, but we don't know exactly the genes responsible for these mutations. Who is appropriate patient for germline testing? Younger age at diagnosis, high-grade disease, recent score more than 7, multiple generations of cancer, and multiple family members with same cancer, prostate, breast, ovarian, pancreatic, and Ashkenazi Jewish ancestry. The 2020 Nccn Guidelines, germline testing is recommended for patients with prostate cancer and any of the following: high risk, very high risk, regional or metastatic prostate cancer, Ashkenazi Jewish ancestry, familial history of high risk germline mutations, BRCA1/2 Lynch mutation, and complete family history, and limited data suggest cribriform histology may be associated with mutations. What to test? This is the germline testing, what we know: BRCA1, BRCA2, and CHEK2, and the Lynch syndrome. And these are the genes responsible for the mutation for the hereditary prostate cancer. How can we do this germline testing? Via blood, saliva, or buccal swab. Variety of companies, quality and price. It is not covered by the insurance. It costs around $200, and possibility of variable results based on assay and company, not very exact. In conclusion, we are in the early stages of understanding the heritable factors contributing to prostate cancer. We are not knowing the exact genes responsible. Patients, we have to ask the patients about their personal and family history. If there are cancers in the family, prostate cancer, or any other cancer, you will identify mutations that directly help men and their families. What about the diagnosis of prostate cancer? The role of MRI. Earlier, we used to do prostate biopsy through a transrectal ultrasound guided biopsy. With this method now is is used less and less because of the availability of MRI. And this ultrasound guided prostate biopsy will miss 30% of the cancers. How to do a prostate needle biopsy? We have several methods: the finger guided biopsy, blind biopsy, the image guided biopsy by ultrasound. It can be transrectal, transperineal, end fire, side fire, and the MRI guided biopsy, or MRI ultrasound fusion. Why to use MRI to guide biopsy? Because we can direct the biopsy to the region of suspicious tumor, and we can avoid biopsies in men with negative MRI. Beware of false negatives. How MRI works? The radiologist can tell you better about how it works, but it is a multi-parametric MRI acquired. There are in the prostate region of interest identified and scored by the radiologist using the PIRAT score. And this is how it's looking like. And a multi-parametric MRI. This in white is the suspicious area. Cancer is hypointense on T2, and most important in sequence for cancer in transitional zone. DWI, cancer is high signal intensity on DWI. Most important sequence for cancer in peripheral zone. Can add support to T2 in transitional zone. And this is the ADC map. Cancer is low signal intensity on ADC. And DCE, cancer takes up contrast, can add support to DWE in peripheral zone. This is a very specific things which the radiologist can tell more about it. How to interpret the PIRAT score? PIRAT score 1 is highly unlikely to be cancer. PIRAT score 2 is unlikely to be cancer. PIRAT 3 equivocal. PIRAT 4 is likely to be a cancer, and PIRAT 5 highly likely to be a cancer. How reliable is a positive MRI? In case of, there are several studies at centers of excellence who are doing frequently MRI guided biopsies. For PIRAT 3, 12% positive, for PIRAT 4, 60%, and for PIRAT 5, 83%. Another study has shown PIRAT 3, 21%, PIRAT 4, 58%, and PIRAT 5, 81%, also a center of excellence. And MRI increases detection of clinically significant cancer between 18 and 95%. And suspicion PIRATS grade on MRI correlates with likelihood of finding clinically significant prostate cancers. The combination of targeted biopsy plus standard core maximized detection of clinically significant cancer. In case of a negative MRI, 30% of men could avoid biopsy, and you can reduce detection of low-grade cancers by 15 to 58%. But what would we miss? We will miss 13 to 15% high-grade cancer in case of negative MRI. So this is the benefits. As I've told you, omit biopsy 30%, over-diagnosis low-grade 15 to 58, and 15% will be missed. Summary and take-home points: combination of MRI targeted and systemic course maximized detection of high-grade cancers, 30% reduction of 30% avoid biopsy, low risk, reduce low risk detection, low risk cancers by 15 to 58%, and you miss 15% of high risk cancers. How I use MRI results: if it is negative, usually to standard biopsy, PIRAT 3, standard biopsy plus menace target biopsy, PIRAT 4 and 5, always do standard biopsy and targets biopsy. Technique of the prostate biopsy, I've told you what the patient are afraid all the time of, the complication and the side effects of the biopsy, which are perineal discomfort and pain, the 24 hours following the biopsy, hematuria 4 days, and hematospermia maybe 4 months are common. Severe rectal, or if in case of hemorrhoids or urethral bleeding, can happen but are uncommon. The most important complication is the infection and can go to sepsis, and you should hospitalize the patient. Lower urinary tract symptoms, up to 25% have LUTS. Less than 2% they may have urinary retention. Higher rates reported after transperineal biopsy. Mortality rate is rare. Erectile dysfunction also rare. How to minimize infection: use conventional antibiotics, do urine analysis and culture before the biopsy, as they should be negative, and conventional antibiotics plus parenteral aminoglycoside. I used to give also carbapenems. Pre-biopsy rectal swab, we are not doing it because we use perineal biopsies. Formalin needle dip, we are using it to reduce the infection each time we put the needle inside, and transperineal approach is more appropriate than transrectal approach, less infection rate. In summary, prostate biopsy preparation and technique has been highly refined over past 2 decades. Antibiotic prophylaxis, it's helping proper local anesthetics, and the transperineal approach is preferred. What is very important is a proper follow-up after you will get the pathology and check the abnormal pathology. Sometimes you do biopsy and the patient get lost, and after 6 months or 1 year, you will come back with a metastatic disease. Really to register and follow the patients. After 15 days, if he'll not come, you call him to come back. A small conclusion. Prostate cancer diagnostic is evolving. The way we do the prostate biopsy, the MRI avoid unnecessary biopsies, but we have a risk to miss 15% of cancers, and biomarkers are not so important nowadays since we are not using them and they give no definitive result. Thank you for your listening.
Thank you, Dr. Muhammad Musa. It's an excellent overview of screening, early stage, MRI biopsy, etc. So unfortunately, Dr. Musa is not with us to answer the questions. And since we are running beyond the 20 minutes beyond the regular time, so I ask, unless among the panelists there is any comment or question. If not, I'm asking Dr. Marrawi to introduce the next speaker.
Okay, thank you, Dr. Muhammad Musa, for this nice presentation. If there's no question, I present the third speaker. The third speaker for this meeting is Dr. Khalid Ibrahim. He's clinical associate professor of hematology oncology at University of Beirut.
Thank you.
He will talk about impact of latest treatment paradigms in metastatic hormone sensitive prostate cancer. Please, Dr. Ibrahim.
Thank you, Mr. Chairman. Okay, so first of all, what we're going to discuss today is the benefits of chemohormonal therapy in castration-sensitive prostate cancer. A very small niche here, high volume versus low volume disease. The second thing, the androgen receptor pathway inhibitors in combination with docetaxel in the management of castration-sensitive prostate cancer, choosing between docetaxel and an androgen receptor pathway inhibitor in CSPC, the role of triplet combination therapy, utility of PSA in metastatic CSPC, and the ongoing phase 3 trials on ADT in this indication. So I'm not gonna stop here for a long period of time. Now, everyone knows that for the history of the disease of prostate cancer, we have the first part, which is the non-metastatic, the second part is metastatic, and the non-metastatic part, we end up by having a non-metastatic castration resistant, where many trials used enzalutamide, apalutamide, and dolatumide. I think we will have some possibility to talk about the third drug. Maybe if we reach the possibility of discussing the triplet therapy view of the time. Now, the other part, which is the history of prostate cancer, metastatic, and what we're gonna discuss today is a very it's a very unique part, if you want, in this in the history of metastatic disease, is when the patient is castration sensitive. We didn't reach yet the castration resistant, and so the current management of prostate cancer is, it's a very busy slide here. So probably we're gonna discuss all these possibilities during the presentation. But before going into the presentation, I would like to guidelines for the first line treatment of metastatic disease, where it's very well established that we do not offer ADT monotherapy, chemotherapy to patients presentation is M1 disease and who are fit for docetaxel, abiraterone plus prednisone, or APA or ENZA to patients who first present with M1 disease and also are fit enough to the regimen. Now, some housekeeping points for the audience. especially we're not oncologists, what is the biochemical recurrence without metastatic disease? It's the elevation of PSA in patients with prostate cancer after treatment, surgery, PSA of 0.2 nano per milliliter, and a confirmatory value of more than 0.2 nanogram per milliliter after radical prostatectomy. And the third point is the radiation, the Phoenix criteria, which is nadir +2 after radiation. Castration-sensitive prostate cancer, which we're gonna discuss today, is prostate cancer that has not been treated with ADT or remain responsive to ADT. And castration-resistant, it's many points here, but basically is the disease progression despite ADT and a castration level of testosterone less than 50. And the last is the high volume disease that we should know about. It's the presence of visceral metastasis and or more or equal for bone metastasis with at least one outside the vertebral column and pelvis. So what we're gonna discuss is the prostate cancer that has not been treated with ADT or remain responsive to ADT. Next slide. What is the evidence that we have? We have 7 trials. The shorted trial who looked at the ADT plus docetaxel versus ADT alone with a benefit in overall survival. The same thing applies to Stampede ADT versus AD plus docetaxel, also with a significant overall survival. The Stampede ADT alone, ADT plus abiraterone, I think it's the fourth or the fifth arm of the study, also showed a benefit in overall survival. We're talking about the same niche of patients. The Latitude trial, which looked at ADT plus abiraterone versus ADT, also showed an overall survival and the radiological PFS significant. Titan used as a comparative arm ADT, but it was a combination of ADT plus apalutamide, also with an endpoint of overall survival and radiological PFS, also significant. Arches, which is the enzalutamide trial, ADT versus ADT plus enza, radiological PFS significant. And the last one is the enzamet that looked also as ADT plus enzalutamide versus ADT, overall survival benefit. Just a flavor of these trials: docetaxel in metastatic hormone sensitive PS, prostate cancer, 2 major trials, as I told you, the Charted and the Stampede. The Stampede is a randomized open label multi-arm trial, phase 2, phase 3 trial, 1,917 patients, where we have the 6 arms: arm A ADT, then ADT plus zoledronic acid, then ADT plus docetaxel, then ADT plus zoledronic acid and docetaxel, ADT plus abiraterone, and ADT plus radiotherapy to prostate. Looking at the overall survival in Charted and Stampede, it was statistically significant in terms of hazard ratio and p-value. Now, compare the efficacy of docetaxel plus ADT. It was highly effective. If you look at the left part of the slide, it was highly effective only in high volume or de novo metastatic hormone sensitive prostate cancer. It wasn't significant in patients with low volume disease. The same thing applies to Stampede trial with high volume versus low volume disease. Now reaching abiraterone. Abiraterone was looked in the Latitude and Stampede trial in advanced prostate cancer, with an overall survival in Latitude in favor of abiraterone plus ADT, and in Stampede also abiraterone plus ADT showed significant benefit. ADT, as I told you, plus abiraterone showed an overall survival in long-term follow-up in de novo metastatic hormone sensitive and high risk Latitude criteria, as I mentioned there. Also, in both studies, the hazard ratio in latitude was 0.66 with the p-value significant 0.30, and in the STAMPEDE also the hazard ratio was 0.63 and a p less than 0.001. What about novel hormone aptamide and enzalutamide? Titan trial, I will come back later on to the design of this trial. The radiological PFS and overall survival were both significant. The ratio of 0.48 for the radiological PFS, significant p-value. The same thing applies to overall survival with a hazard ratio of 0.67, around less 30% death. The ARCHES trial overall, which looked at enza plus ADT versus placebo plus ADT, significant p-value, hazard ratio 0.9 in terms of radiological PFS, which is the primary outcome that was looked in this trial. Survival, the hazard ratio of 0.81 with a p-value not significant, but to take consideration that the survival data at that time were with only 14.4 a month median follow-up and 84 deaths. So probably it's underscored here in terms of overall survival. Okay, you can skip this. So in the summary, the doublet therapy for MCSPC, all eligible patients should be offered treatment intensification upfront. The choice of agent, whether it's docetaxel, abiraterone, APA, or ENZA, it depends on cost, adverse events, in context of patients' comorbidities. Docetaxel is less expensive, yes, complete after 6 cycles, and offer while chemotherapy, but we should not forget about the side effects. Abiraterone, generic, requires potassium, LFTs, blood pressure monitoring, concern for long-term hypertension and prednisone. ENZA, less monitoring required, concern for neurocognitive issues, including seizures. APA, less monitoring required, concern for rash neurocognitive issues. Now, subgroup analysis from STAMPEDE support radiotherapy to prostate, as we discussed in one of the cases. Radiotherapy to prostate in conjunction with ADT for low volume disease, benefit with best systemic therapy. What considered for our patients? Well, the patient is concerned about how many clinic visits, how often, how long will I need this treatment? It's a question that we hear. Pills or IV also is very important. How does this affect my ability to work or care for my family, and how much this will cost? So these are things probably that we should take into consideration whenever we are approaching our patient and discussing the possibilities and the treatment. Now, it's the first part. It's an overview, and I think I didn't tell you anything that you don't know, but it's like a kind of setting the scene. Now, the guidelines recommendation 2021 treatment option for this kind of patients: ADT plus abiraterone, apalutamide, enzalutamide, docetaxel. We should not forget about ADT plus EBRT to primary tumor for low volume disease. How to choose, quality of life and patient preference must also be considered. Now, my last part of the talk. So I will try to update 2 or 3 abstracts that were presented at ASCO GU 2022. Now, back to the Titan, the APA plus ADT versus placebo plus ADT. It's an international randomized double-blind placebo-controlled phase 3 trial stratified by Gleason score, region, and prior docetaxel, yes or no. Patient with metastatic castration-resistant, sensitive prostate cancer with good performance status, prior ADT, less than 6 months, less or equal 6 months for metastatic CSPC, or less than 3 years for local disease, randomized for APA standard dose of 240 milligram plus ADT versus placebo. And the treatment to be continued to progressive disease with primary endpoint overall survival, radiographic PFS, and other secondary endpoints, including pain progression, time to SRE, time to chronic opioid use, and others. Now, in the Titan, as I showed you, the radiological PFS and overall survival were both very significant. Now, if you take this study with the significant positive results, and you go for a subset of the patient. In the ASCO 2022, they looked two parameters. First of all, the title PSA kinetic and impact on prognosis. First abstract is attainment of early deep prostate specific or PSA response in metastatic castration sensitive prostate cancer, comparison of patient initiated APA versus ENZA. Now, we know that attainment of the early deep PSA response has an impact on survival. And the rationale, and it was a randomized controlled trial, and the rationale was that rapid, deep, and durable reduction of PSA with next generation ARI is associated with increased probability of achieving survival outcome. This is the first thing. And on the other hand, there are no data comparing the rate of PSA outcome among patients with metastatic hormone-sensitive PSA using APA or ENZA in the US. So this is data from the US with the endpoint proportion of patients who achieved PSA 90 and time to PSA 90 response from the date of the randomization index treatment. And what they found in this study, that there was a significantly more patient treated with APA attained PSA 90 by 6 months, and beyond that, these treated with patient with ENZA with a significant p-value of 0.021. So is the median time for PSA 90 was 3.1 months for APA patient and 5.2 months for ENZA patient.
Dr. Khalid, you have run already 30.
Okay, I'm gonna finish.
Take 5 minutes each.
Okay, next slide. I will not stop with the conclusion because already I was discussing this, but the thing that I want to mention is the proportion of patients attaining a PSA 90 response by 6 months and 12 months was observed following initiation of APA. They are consistent with those observed in the Titan phase 3 trial of APA in this setting. Next slide. Yeah, I think this is the last slide that I have. They looked at in another abstract at the ASCO. They looked about the association between patient-reported outcome and changes in PSA in patient with advanced prostate cancer treated with APA in the Spartan and Titan study. Next slide. The interesting thing, the conclusion here, that patient with metastatic hormone-sensitive prostate cancer who achieved PSA decline of less or equal to 0.2 nano per milliliter, they had a lower risk of deterioration and quality of life, which is also a very important point to discuss. And the PSA decline with APA plus ADT, they observed a rapid and deep PSA decline, and it was associated with extent of the survival. Since I'm running out of time, I'm gonna stop here, and I will leave the other points to be discussed later on. Thank you.
Okay, thank you, Dr. Khalid. Nice presentation. I don't know if we have time for receiving questions. Perhaps one question.
We have time.
Please.
We have time, please. No, I think the topic is very important, and we can have some discussions, if any. Okay, I think we need to talk about that. And Mr. Chairman, Dr. Deborah might animate the discussion. What do you think about what has been done? What's the take message, the most important take message from this?
I mean, if I could, this is a great summary, but the most important take-home message is that ADT alone is not an appropriate choice.
Yeah.
We have so much level 1 evidence.
Yes.
Men treated with ADT alone. So this is number 1. So I think, do we all agree that ADT alone is not appropriate anymore? So that would be my main message. I see Dr. kind of nodding his head. Choice is up to you and your patient, but I think this is the most important point to get across to the audience, that we need to advocate for intensification of therapy based on lots of level 1 evidence.
Yes. Okay, actually, what I skipped here, and this was something that I wanted to discuss with you. What would be your opinion about the triplet treatment in this setting? And I'm talking about the PIS1, and I'm totally interested in data that was presented. I think you all aware about a very interesting data that was presented in the last 1 month ago in the Arasens tribe.
Yeah. If you allow me, Dr. Khalid, I can comment. I think
Yes.
it's very important options, and also one of the areas of improvement, especially if we are looking for the overall survival benefit with the intensification of the treatment. I think the main thing. Yeah, I think the main thing, when the PIS1 study reported for the first time in ESMO, and there was a progression, radiographic progression-free survival initially, and then later on the overall survival, we are talking about in the progression about 2.5 years improvement compared to the control arm, and 1.5 year of overall survival compared to the docetaxel, maybe ADT. Now we have the Arasens, also the darolutamide showed both radiographic progression-free survival, overall survival. I think the remaining question is, who are the patients to be selected for that protocol, maybe giving the toxicity profile. And I think maybe until this time, maybe we'll not.
On the other hand, yes.
Yeah.
Because on the other hand, also we are lacking biomarkers.
Yes.
And just to select patients who will benefit from this approach. It's but I just wanted to mention for the audience that the PIS1 is a very interesting study. There's abiraterone plus radiotherapy, and it's, but the interesting part is that the study was amended at the end of the day in 2017 to make docetaxel mandatory in the SOC, yes. which wasn't the case at when the trial started.
Exactly, that was for the PIS1. Yeah, for PIS1, the standard arm was evolved over time from ADT to ADT plus docetaxel, but it was not for the Arasens. It was the standard arm was very clear, I think, from the beginning. So I think we are not doubting maybe the efficacy of the triplet therapy. It is maybe who will be the best to receive that combination, giving the toxicity with both the docetaxel as well as the.
I agree. I fully agree with you, because it's if you look at the study design, we have a lot of variation between patients, and at the end of the day, it's not an easy treatment, and it's a costly one. So probably the next step is to try to stratify patients who will benefit here from the others. I agree.
It's a difficult one. I think if we choose the patient who you may want to use a triplet therapy, it would be the young patient with very high volume disease with symptoms that you want to treatment. The patients who have relatively low volume disease do very well, without chemotherapy upfront. So I think those would be the patients that I would choose for triplet therapy.
Sure.
Thank you. Thank
Okay,
you,
good.
Ali. So with these encouraging results from triplet therapy in hormone-sensitive prostate cancer, now we move to our last speaker, Dr. Mubarak Al-Mansour. Mubarak Al-Mansour is a medical oncologist, chairman in Princess Noura Oncology Center, King Abdulaziz Medical City, and associate professor at College of Medicine, King Saudi bin Abdulaziz University for Health Sciences, Saudi Arabia. Dr. Mubarak Al-Mansour will talk about the remaining challenges in metastatic castrate-resistant prostate cancer management. Dr. Al-Mansour, the podium is yours.
Thank you so much, Dr. Qattan, for the nice introduction. And I would like to thank the organizing and the scientific as well as committee. And I think the part is covering here. I will be, do you hear my voice and do you see the slides clear?
Yes.
Yes, everything is clear.
Okay.
Yes.
I'm just trying.
Yes.
Okay. So I will just with this, and I think this is a familiar face to most of the people treating the prostate cancer. The Charles Huggins, who was awarded the Nobel Prize in Physiology in 1966 when he presented his evidence in a paper, significant improvement often occurs in a clinical condition, a patient with far advanced cancer of prostate after have been subjected to castration. That concept still this time is one of the pillars of management of the prostate cancer is the castration, either biochemical or surgical. Dr. Khalid nicely highlighted the landscape and the change into the management of the hormone sensitive. And now through the multiple studies addressing the role of the chemotherapy with the charted stampede to the novel agents, as well as the latitude, titan, and enzamet. And lately we have the triplet through the PIS1 and the aracens with the darolutamide and as experimental arm. And the comparator was almost all the time ADT or the ADT plus docetaxel. I'm presenting this slide because any thing will be used into the front line to treat the hormone-sensitive prostate cancer will affect your choices later on when the patient achieved the castration-resistant stage. So those are the stages or the states into the prostate cancer, either starting with the localized, progressing to a biochemical, and then to M0 CRBC, and then to a metastatic, or presented with a metastatic hormone sensitive from the beginning, and then progressing to metastatic castration prostate cancer, and then going from one line to another. I think the mechanism of progression to a castration resistant is very interesting, and that's changing. Again, trying to use the science to overcome that. So a progression to a castration resistant is likely a function of a clonal selection, an adaptation of androgen receptors, because if you ask yourself, patient was initially responding to the hormonal or to the novel agents maneuver and responding through the androgen receptors. Now, what happened? Why those cells are progressing with time? Why did we get this resistance? And most of the experts think that due to androgen receptors, either gene amplification or mutations in those receptors, or maybe finding another survival pathway bypassing the androgen receptors. And that's where the patient reaching the castration stage. That also was presented by Dr. Khalid nicely, that we can see, I mean, since 1940 until 2010, we had just only maybe a docetaxel and mitoxantrone, and then over the last 11 or 12 years, we've seen a lot of options now for the prostate cancer, either into the metastatic or into the castration resistant, either sensitive or castrated level. And now we have multiple options for sure that will impact into the overall survival of patients with prostate cancer. Sorry. So I think the challenges remaining, and this is the maybe the objective of my talk today, is does the treatment sequence matter? And this is just resolving the controversies. And I think that was answered maybe in another way during the discussion. But however, when are we personalizing the treatment to the castration-resistant prostate cancer, we have to take in account a disease as well as a patient's characteristics, and then go through them during your selection for which treatment you will give this patient at this stage. One of the clinical features of the disease is the site of the disease. We've noticed with the bone predominant, maybe one of the options later on is the radium-223, while the visceral metastasis, they might not be a candidate pace of the disease. And we will see later on that those patients who progressed shortly, then the chemotherapy may be the best option comparing to the novel agents. Presence or absence of the significant symptoms. We've seen studies that approved certain medications for asymptomatic or mildly symptomatic. And also maybe the docetaxel initially was approved into the symptomatic patient into the CRPC. Patient health performance status is very important. Comorbidities, and we've seen nicely into the first cases that we've discussed the importance of having another comorbidities and the effect in your choices of the treatment later on. A prior therapy, either with enzalutamide or abiraterone or prior chemotherapy, will have impact. Tumor histology that was also mentioned today, especially if you're seeing aggressive visceral metastasis or changing or other markers that you have to make sure that you are not dealing with another histology, especially the neuroendocrine, basically the small cell carcinomas. Molecular features that I will talk about, especially with the HRR, the homologous recombination repair genes alteration, as well as the MSIs and the role of immunotherapy. So this is my simple way of, and I think this is not just will illustrate everything, but when I face a patient or I see a patient in a clinic with a CRPC, the first question I ask myself is this a post-ADT alone? And you've seen from the discussion that no one is using maybe this modality at the time being giving the options, except maybe for a very well-selected elderly patients, comorbidities that they cannot tolerate either the novel agents, neither the chemotherapy nor the novel agents. So those patients have the options of the chemotherapy or the novel agents, abiraterone, enzalutamide. This is here, just I needed to differentiate. We're not talking about a hormone sensitive because that's done. Now we are dealing with the castration resistant. That's why you don't see the apalutamide, you don't see the darolutamide, because they are not options at this stage. And then those patients who previously treated in a hormone sensitive stage with either docetaxel, you have other options. You can use abiraterone or enzalutamide, radium or PARP inhibitor, the 177 lithium PSMA that we'll talk about, cabazitaxel is option. The same for those received ART is androgen receptor targeted therapy. So you can give them a docetaxel. We'll see about the other rules of other novel agents and the cross-resistant, and you still have the radium or the PARP inhibitors or the PSMA lithium 177. And then after receiving the first line for the CRPC, going to the second line will be also impacted by the choices into the first line. So I'll try to just present tables to summarize because the time. So this table is a post-ADT alone. And as I mentioned, rarely will face a patient now, except if they are there in the clinic for a long time and they were responding to ADT and still maybe fit to receive other agents at the castration resistant level. But you can see here that tax 327, this is the one was reported in 2004 by Tannock, the docetaxel versus the mitoxantrone, which considered to be at that time the chemotherapy agent. There was overall survival about 3 months. And then later on, cabazitaxel was tested into the post-docetaxel through the TROPIC study, and it showed overall survival benefit with the 30% reduction into the death translated to 2.4 months. And then a question was, can we use cabazitaxel instead of docetaxel into the front line of CRPC metastatic stage? And that showed non-superiority of cabazitaxel. And then the study was comparing 2 doses of cabazitaxel, 25 milligram versus 20 gram. It showed that the 20 milligram is not inferior to the 25 and less toxic. So from this table, we can say that docetaxel is still the preferred first line therapy. If needed to use a chemotherapy, cabazitaxel can be used as a second line chemo when needed. And then 20 milligram cabazitaxel is the appropriate dose with the less toxicity compared to 25. And then the novel androgen agents, especially with the abiraterone and enzolutamide. The first study was the COU AA301, abiraterone post-docetaxel. And then followed at that time, there was also the AFFIRM study testing the enzolutamide post-docetaxel. And then both of them tested in a pre-docetaxel setting, still into the CRPC stage. And you can see here the overall survival in all those settings, either pre or post-docetaxel, either using abiraterone or enzolutamide showed overall survival benefit ranging between almost like approximately 3 to 4 months. So here I need you just to focus, if we compare the overall survival benefit of the abiraterone into the hormone sensitive, into the latitude, or into the enzolutamide, into the enzamet, or the apalutamide, and you can appreciate the differences here. You can see just only a 3 months overall survival benefit. While if you use them in the earlier stage, you are reaching more than 15, maybe 16 months also overall survival benefit. And that's why Dr. Deborah was saying the ADT is not enough. That's why we have to use other agents giving the survival benefit in the first line. Impact trial for the Spileucel also, which is not popular and used. I think I don't have any experience with this, and I'm not sure if others used it or not. Maybe that's in the discussion. Radium-223, we have patients on it post-docetaxel, and it's one of the tolerated patients. If you select your patient very well, it showed a 3 months overall survival. So this is the post-dose ADT. You have the docetaxel, you have abiraterone, enzolutamide, you have later on post-docetaxel, you might use a radium. So what about those patients who received a docetaxel in the first setting? There is no reliable evidence what to use. Do I use abiraterone, enza, radium, cabazitaxel? As we discussed initially, there is no single biomarker to tell us, except maybe later on when I will talk about the personalizing maybe or precision medicine. But here it depends. One of the things that you can maybe use in your clinical sense is time of progression. If the time progression is less than 12 months post upfront docetaxel, you can use cabazitaxel because you can sense that the disease is aggressive and maybe the novel agents will not be enough to overcome that. If the progression more than 12 months, some experts, they suggested or maybe leaning towards using a novel agents, either abiraterone or enza. And then the question now, if I used, for example, docetaxel or abiraterone into the first setting, can I still use another agent like enzolutamide post-abiraterone? Most of the literature says there is no data available maybe to suggest which is which, except one study that I will show you. But a concern usually about the cross-resistance between those targeted agents and a poor response to Abi post-enza and poor response to enza post-Abi. But this is one of the multi-center optimal sequencing enza and abiraterone and in a multi-center randomized open label, and data was suggesting, it's not maybe a confirmatory because this is still a phase 2 and just only one study, that if you use maybe abiraterone followed by enza, you might get maybe the greatest clinical benefit compared to versus the abiraterone. CARD study was answering the question is, if a patient progressed post-docetaxel, then the next option, can I use abiraterone or enza or cabazitaxel? Which agent can I use? The novel agents like abi or enza or cabazitaxel? CARD study answered that question through a randomized study where they included a patient with a castration-resistant prostate cancer, metastatic, previously treated with a docetaxel, and then randomized them to receive a cabazitaxel versus either abiraterone. If a patient received before inclusion in this study enza, then he will be on the abiraterone arm and vice versa. So cabazitaxel versus either abiraterone or enza, and the primary endpoint was a progression-free survival. Here is very important to notice that one of the inclusion criteria is a progression in 12 months or less, so indicate that there is a disease aggressiveness for those patients. That study showed both radiographic progression-free survival, overall survival benefit, with cabazitaxel versus abiraterone. So maybe one of things that we can use if patient progressed in docetaxel in the first line in a metastatic castration-resistant cancer, and they are 12 months or less, we have the CARD study results suggesting that cabazitaxel might be the best option given the progression and the overall survival benefit. So moving from a docetaxel, cabazitaxel, enza, abiraterone, or the radium to now we have more options for the prostate cancer. Now we have something they call the personalized medicine or phenotypic precision, where you can use either into at the gene level. We know that more than 20% of patients with a metastatic castration-resistant prostate cancer harboring the HHR gene mutations that we will talk in the next few slides. And we have the options of the PARP inhibitors. Also, there are 3% with the MSI high, and those are the Pembro. And this is why we were in the discussion part with one of the cases that we don't use a Pembro if there is no MSI high for those patients, and there's was not tested. The other options here is the PSMA expressed in about 80% of prostate cancer patients. And now we have the VIGIN trial evaluating the role of the 177 lithium PSMA that I will talk about later on. So before going to the PARP inhibitors, this is the normal cell. When there is a breaking into the DNA, we have two mechanisms to repair that, either through the HHR recombination gene, which is the homologous recombination repair genes like BRCAs and other, they would repair especially the double strand breaking in the DNA, or the PARP involved into the single. However, if you have a mutation in one of those HHR genes, then the rest will be done by the PARP. And if you use your PARP, you will not fix that DNA for the diseased cell or the cancer cell, and that will lead to a response. So that's the theory behind using the PARP inhibitors. And you can see into the germline alteration in one of the studies in about 19%. However, if you collect somatic and germline alteration, you might achieve more than 27% either induce a gene. And you can see here the most maybe gene affected is the BRCA1 9%, and also somatic only in a BRCA2. BRCA2 is BRCA1 is 9%. And BRCA1 is 1%, and here BRCA2 for the somatic also reaching about 8%. So a profound study, one of the landmark studies, where a patient with a metastatic castration or a metastatic CRPC who progressed on abiraterone or enzalutamide and also received the previous docetaxel were stratified. randomized to two cohorts. The first one, they included all the cohort BRCA1, 2, or ATM genes mutation, and randomized them to either olaparib or the physician's choices. The second cohort, they included the other alterations apart from BRCA1, 2, and ATM. And the primary endpoint was the progression-free survival. So you can see here cohort A, BRCA1, 2, and 3, and and ATM. It showed there is a progression-free survival benefit, which is clearly, and you can see here the hazard ratio 0.34. So we are talking about maybe a 66 maybe % reduction into the progression, radiographic progression, as well as into the A and B as a progression free survival. But if you go specifically to the overall survival, it was noticed into the cohort A, and it was clear. However, into the cohort B, there was no overall survival benefit. And that's most of the people saying, if you have a BRCA1, 2, or maybe ATM and those genes, you can maybe justify for using the olaparib according to this data. Rucaparib is the Triton study, also more or less the same inclusion criteria. However, rucaparib was given a 600 milligram BID, and just because of the time, radiographic progression-free survival was a 9-month. So according to the USA FDA approvals, both rucaparib and olaparib approved mainly rucaparib for the BRCA mutation and olaparib for the HHR gene mutation MCRPC stage. You can see in this slide a lot of combination with PARP inhibitors, and we are expecting a lot to see in the future, like olaparib, abiraterone. We will talk about it later in the PROBAL trial. However, Pembro, radium, all these things, they are trying to do now a doublet, as was done into the initial studies. Prostate specific membrane antigen, the PSMA, is a type 2 transmembrane glycoprotein that highly overexpressed in a prostate cancer and increased during the castration-resistant stage. And the VISION trial was a study that including the patient who previously treated with one or more of androgen receptors inhibitor or docetaxel, and randomized them to either lithium-177 PSMA every 6 weeks for 4 cycles or 6 cycles, compared to the permitted standard of care according to the investigators' discretion. And also they included those with a good performance status, with a good life expectancy. And it should be, that's very important, a PSMA positive stage by either on a PET CT or with PSMA material. That's why I was saying highly expressed, but not all the cases. So it should be tested initially for the PSMA. You can see in that study all the 3 endpoints, either the progression-free survival imaging or overall survival, or the time to first symptomatic skeletal event were met, and that study was positive. From the last ASCO, and this is the last 2 or 3 slides, a magnitude study. It's one of the studies in the first line MCRPC. They included the 2 cohorts in those patients. They included HRR biomarkers positive, and those are the biomarkers either with the BRCA1, 2, or ATM. Or they also included another cohort of patients, which is HRR negative. And someone will ask, yani, why we are using a PARP inhibitors in someone who have negative markers. However, that was the study of the design, randomized to niraparib plus abiraterone in both arms. And the patient with biomarker positive, the radiographic progression-free survival was clearly superior to the PARP with the niraparib plus abiraterone with a hazard ratio of 0.53, as well as the radiographic progression-free survival by the investigator and also by the central review. However, in those with the biomarker negative, there was no differences, and that makes sense in this study. However, the other study, which is the PROPEL study, more or less the same, they included also a patient with the first mCRPC, docetaxel allowed. However, here, olaparib plus abiraterone given, and the placebo plus abiraterone. So in this study, the biomarkers were assessed retrospectively. So the study was done, any patient, they randomized them regardless to the biomarker status. However, later on, when they went back to see the biomarker, it was in that study that those patients with the biomarker positive, they benefited for sure, as well as with those with the biomarker negative. However, that's still a big question mark during the discussion, and that's why till this time, everyone is waiting to see that subgroup of patient in that negative, they might have already a positive, and because there was maybe a discrepancies between using the gene detection method from the foundation one study compared to the other. The side effects with the abiraterone and olaparib as was expected. So in a conclusion, I think early treatment, and this is why we have to stress tonight, is you have to use the best option in the first line at the metastatic hormone sensitive setting with the options at that group. Sequential treatment still routinely used. However, we don't have a single, I would say, recipe to suggest which way to go. You still have to use the disease as well as the patient characteristics, plus the other precision medicine like the PARP inhibitors into the HHR mutated patient, or immunotherapy induced with the high MSI. A clear cross-resistance between abiraterone and enzalutamide, and this might be the case in the future also, even if you use apalutamide or darolutamide in the initial stage. Taxane is still active after ABI and ENZA, and we've seen that according to the CARD study, especially in those less than 12 months. Biomarker-driven medicine, finally, we have them with the PARP inhibitor and the PSMA. And with that, I would like to thank you all for your attention, and I will be happy to take any questions.
Thank you, Dr. Al-Mansour, for this excellent overview. You show us the algorithm if these patients get previously taxane or new generation anti-androgen. So now with the triplet therapy in hormone sensitive, the choice will be more and more difficult. What do you think?
Well, I agree. I think this is important. The landscape into the hormone sensitive make it very difficult and complex later on. So I think using maybe the abiraterone with the docetaxel, is that going to respond maybe to a single agent ENZA later on? Difficult to maybe answer without any data, but for sure I think this is something of the challenges into the mCRPC setting, is those treated with the triplet therapy. However, we that using those active agent and intensifying the treatment will maybe delay the progression to the mCRPC.
Is there any question among the panelists or among the attendees? You can fill for the Q&A box here if there is any question among the attendees.
Dr. Katan, you can challenge, you can ask about this challenge, Dr. Mukherjee, Dr. Adib. So I would like to hear your opinion.
What to do, absolutely.
And I'm not here with what you said.
So I think we're going to be using more cabazitaxel and more lutetium PSMA, which was just now FDA approved. So the VISION study was quite controversial, but actually gave the lutetium PSMA before cabazitaxel. And there are some men who respond very, very well. So our paradigms are going to be shifting, but we'll definitely be using more cabazitaxel and more lutetium PSMA.
Agreed.
We have a question. Can you read it, Joseph?
great questions. When to use a PARP inhibitor? Is there a best sequence among all the new agents? It's a tricky one.
Yeah, I think this is a good question. And before that, when do you test maybe for the mutation? That's one of the things. Still, we don't have maybe a clear answer. However, what we are doing in our practice is, especially, let us just give the scenario of giving maybe the triplet therapy now, docetaxel and maybe abiraterone. I usually request to see the PARP inhibitors or the mutations. I'm sure this is maybe into the other centers sponsored by a company through the lab. As you can send through for those biomarkers, especially with the AstraZeneca primarily in our institution. So I usually send it when I see the patient maybe approaching the castration-resistant prostate cancer. However, I can do it from the beginning, but later on, if there is a very aggressive disease, and you can do maybe another biopsy, that will be good, maybe to send that fresh tissue to for the testing. If I have a patient who progressed into the first line, reaching this BC and BRCA 1 or 2 mutated, that's the time I will use them. Maybe before the other agents. However, you can maybe the argument saying into the inclusion criteria, the patient already exposed novel agent or Inza or docetaxel. You agree that's the study design. However, maybe you will be using all those options later on at some point. So using a one option doesn't mean that you cannot use the others later on, but you are trying maybe to get at least when I see something, a biomarker driven decision and strategy, I might feel maybe more comfortable using that agent at this stage. Yeah, so I will do, that's the way I do it. And if it's positive, I go with the PARP inhibitors rather than other agents.
This is a really excellent point. And I think that you also made the point that not all biomarkers are equal. And the patients, I think in our case, the patients with the BRCA mutations will respond exceptionally well to PARP inhibitors, whereas things like ATM, the responses are not as encouraging. So although they may be approved for all of these different HRR mutations, it's actually the BRCA1 and 2 mutations which respond best. So that also goes into our decision making.
I think here there is a question, any role for combining the upfront PARP inhibitors plus abiraterone or Inza as per the protocol into the hormone sensitive? No, talked about the magnitude and also the propel trial into the first line mCRPC. However, I think more still waiting for more data and maybe more maturity, especially for the survival. So if I will use a PARP inhibitor, it will be a single nut and abiraterone or Inza at this time.
And who knows, with the stampede bringing PARP inhibitors to the much earlier settings, we may have an even better survival benefit using them earlier. And there's also some really interesting data about combining PARP inhibitors and lutetium PSMA with the DNA damage repair. So that's also studies on.